Director of Doherty Institute of Infectious Disease and Immunity, Melbourne, Australia, and Juergen, the head of HIV Outpatient Clinic, University of Bonn, and also the activist in the HIV field, Giten Khwairakpam. So we'd like to start with the first speaker on ending hepatitis B. So Sharon, please.
Thank you, Anchalee. For those of you that were here in 2013, Juergen and I did debate that we would see an end to HIV in our lifetime. Unfortunately, Juergen won and I lost, so I'm still hurting from that. And as a result of that, I've now moved to hepatitis B. No, not really. I've always worked on hepatitis B and HIV, and actually done a lot of my work here in Thailand on hepatitis B with Dr. Anchalee. So I was really honoured to be giving this talk. It's ending hepatitis B virus. If we had the debate today, I think Juergen and I may see this in our lifetime. I'm far more optimistic about that. So just in exactly a year ago, Tony Fauci had an op-ed in the Washington Post, and the title was "No More Excuses, We Have the Tools to End the HIV/AIDS Epidemic." And we hear this a lot, but really you could just as easily and probably far more confidently say that we have those tools for hepatitis B and hepatitis C. And as again Tony Fauci often says, this is a problem around implementation, and again so relevant to hepatitis B and hepatitis C. So to eliminate any infectious disease, you need a strategy for prevention, you need a strategy for treatment, you preferably should have a vaccine, and in a lifelong infection like HIV, hepatitis B and hepatitis C, I still think you do need a cure to see elimination. But as I said earlier, probably the most important thing, if you have any or all of these, is around implementation, and my talk's really primarily going to focus on implementation. So for hepatitis B, we have excellent ways to prevent hepatitis B through screening the blood supply, through access to clean needles, through public health messaging. We have actually fantastic treatment for hepatitis B. As opposed to HIV and Hep C, it's the only bloodborne virus that we have a highly effective vaccine. We still don't have a cure. And last year I spoke about some of the strategies that are being tested to find a cure for hepatitis B. This is a very active area of scientific investigation, but I won't speak about that today. I'm going to focus my comments on prevention, treatment and implementation. So I'm going to briefly talk about the epidemiology of hepatitis B, particularly globally and regionally. Some review of the recent WHO strategies that both Juergen and I will mention. I think this is absolutely key towards elimination. Some implementation challenges with respect to hepatitis B in the areas of prevention and treatment. And finally, I'm going to review a really recent and very relevant paper on modelling of what will work and what might be the costs. So first of all, the global burden of disease, I'm sure an initiative many of you know about, that's regularly published in The Lancet, recently updated their estimates of the global burden of disease of hepatitis, HIV, TB and malaria. And you can see these four major infectious diseases and their impact in relation to each other. HIV/AIDS accounting for 1.3 million deaths, TB 1.4 million deaths, malaria 855,000 deaths in 2013, and viral hepatitis 1.45 million deaths in 2013. In contrast to HIV, TB and malaria, you can see that viral hepatitis deaths are actually steadily increasing as opposed to decreasing. I think the establishment of the Global Fund for Malaria, TB and HIV has had a huge impact around advocacy, around access to funds and around implementation, and we don't have a similar kind of strategy around viral hepatitis. Perhaps we might see that shortly. And for those that aren't familiar with the global burden of disease or have only looked at it in the Lancet, I encourage you to actually go to the Health Metrics and Evaluation website. This is the organisation led by Chris Murray that generates global burden of disease data, and it's got these fantastic interactive tools where you can drill down and look at trends over time of any infection, any disease you're interested in, particularly any infectious disease, and really drill down into your own countries, for example, where the burden of disease sits in viral hepatitis. So the global prevalence of chronic hepatitis B is shown here. Countries that have the highest prevalence are shown in dark red, and you can see that Africa has a significant burden of chronic HBV. We always think of Asia being most heavily affected, but the areas of dark red or high prevalence are reducing across Asia, largely due to the effective implementation of vaccine programs. So the estimated global prevalence is 3.6%. The highest prevalence is in the South Sudan, in the African region, and an estimated 250 million people living with chronic hepatitis B infection, which is a substantial burden of disease. If we look actually in the Western Pacific region, and I wanted to thank Ben Cowie for many of these slides. I work with Ben at the Doherty Institute. He's the head of a new WHO collaborating centre in viral hepatitis and is very active in the region around epidemiology and advocacy for hepatitis B. So you can see here that if you look at the numbers of people infected with hepatitis B, chronically infected with hepatitis B, most live in China, Vietnam and the Philippines. However, if you look at the population prevalence, there still are many countries that have extremely high population prevalence but just low total numbers. And over 90% of people living with hepatitis B in the Western Pacific region are in China, Vietnam and the Philippines. If you look at the regional distribution of viral hepatitis-related deaths, this is a complex but important slide. It shows deaths related to hepatitis A, B in dark blue, C in light blue and E in a light green. The size of the circles shows the burden of deaths, and then the pie chart shows you which hepatitis accounts for those deaths. And just in a very sort of bird's eye view, you can easily see that most deaths due to hepatitis, at least in the Asia-Pacific region, are a majority related to hepatitis B. You can't talk about hepatitis B or C without talking about the global burden of liver cancer, hepatocellular carcinoma. Liver cancer is the third most common cause of cancer deaths globally and the second highest in respect to years of life lost. Estimated 10% of all human cancer deaths due to liver cancer, and of course most of these due to hepatitis B and C, and therefore deaths are a consequence of poor access to effective treatments to prevent the development of HCC. And again, you can see most of the higher rates of deaths here, here shown in dark blue, sit in the Asia-Pacific region. So what's the WHO doing towards HIV elimination? Well, just last year there was the launch of the Global Health Sector Strategy on Viral Hepatitis from the WHO, which lays out a strategy from 2016 to 2021. Really, really important initiative from WHO. And together with that, a regional action plan for viral hepatitis in the Western Pacific region. So what are the concrete goals of reaching elimination? And some of the targets for intervention are outlined very clearly in this strategy, and I'm going to talk a little bit about these targets, what their targets are at now, which is in the last column on the far right, what the goals are within the strategy to be reached by 2020, and what the goals are to be reached by 2030. And the targets for the strategy cover both hepatitis B and hepatitis C. But first of all, probably the most important target that will have an impact on seeing the end of hepatitis B is childhood vaccine coverage. And you can see that we're doing quite well on that account, currently at about 81%, with a target to be reached of 90% by 2020 and 2030. There are a whole number of other intervention targets that are laid out in this strategy. They include eliminating or having a big impact on mother-to-child transmission through birth dose vaccine coverage, or other approaches such as treating an infected mother with high viral load. Access to safe injection equipment and harm reduction, still both very important, prevention of both hepatitis B and C. Testing is an area that we're doing really badly in globally and regionally. You can see the current estimate of the percent of people with chronic Hep B and Hep C that are diagnosed is sitting at 5%, which is incredibly low. When you think with HIV, where current estimates are sitting at about 50 to 60% globally, and of course vary in different countries. A goal with testing is to reach 30% by 2020 and 90% by 2030. Hep B treatment also, the number of people eligible with chronic Hep B who are actually treated now is at less than 1%, with a goal of treating 8 million by 2020 and 80% of people who need treatment on treatment by 2030. And I think Juergen will talk a little bit about this in the Hep C context. So there are some milestones to achieve some of these targets that are specifically relevant to the Asia-Pacific region. The first and most important one is advocacy and awareness, and we'll hear a bit more about this from the community perspective. Again, with my HIV hat on, none of these targets can be reached without advocacy and community engagement. Target and milestone to develop evidence-based policy in the relevant countries, far better data and surveillance systems, strategies to stop transmission through immunisation, prevention in the health sector and prevention amongst high-risk adults, and then to start getting a much better treatment cascade of the number tested, the number treated and the number of that are suppressed on treatment. And this data actually is still quite difficult to obtain both globally and regionally, but it will be for us to start collecting this data will allow us to implement some of these targets. So what are some of the implementation challenges? I started by saying in hepatitis B we have an excellent vaccine, which is already a big part of the story to see elimination. And the vaccine coverage, at least regionally, has really been a great success story. Here in blue, you're seeing the Hep B, the numbers of individuals, the percentage coverage of Hep B vaccine at the third dose to show complete immunisation. You can see the numbers or the percentage coverage in orange of hepatitis B vaccine at the birth dose, critical to prevent mother-to-child transmission, and in a black line the decline in chronic HBV infections. And you can see that the targets of vaccine coverage, both for the third dose as well as the birth dose, are really approaching up around 80 to 90%. And with this dramatic increase in vaccine coverage, a decline in chronic HBV infections. If you look specifically within the Western Pacific region, what impact this has had, of the 36 countries that make up the WHO Western Pacific region, about 61% of countries were estimated to have a prevalence of over 8% prior to global introduction of the vaccine. This has been reduced to an estimated prevalence of less than 1% following vaccination introduction. This is only in the 61% of countries in the region. There still is an estimated 38 million chronic infections and 7 million hepatitis B-related deaths were averted amongst children born in this time by immunisation programs, so a great success story. And the regional prevalence amongst children born in 2012 estimated at less than 1%. So this has been a very successful program across the WHO Western Pacific region. But we can't be complacent about these programs. This is data that was published last year showing the decline in vaccination rates when there's adverse events following immunisation. This data comes from Vietnam, and it shows you the, in solid line, the percentage coverage of individuals that have all 3 hepatitis B dosages, vaccinations, and the hepatitis B birth dose. Adverse events following immunisation leading to a decline in uptake of vaccination in 2007, and again a recent episode in 2013. And in this modelling paper, there's prediction that in excess of 90,000 chronic infections and 17,000 future deaths were estimated to occur in the 2013 birth cohort. So maintaining these high levels of vaccination is really, really critical. There are some new candidate HB vaccines that are being still developed, such as third-generation recombinant vaccines, different adjuvants, such as toll-like receptor TLR9 agonists, or other adjuvants to improve immune response. And there's some development investment in oral vaccines that could further enhance vaccine coverage. With respect to treatment, this data was actually very difficult to obtain. In Australia, there's been an effort to actually track HBV testing, diagnosis and treatment, and this data comes from Ben Cowie's group. Of course, Australia is a country with a very low prevalence of hepatitis B of less than 1%. But there are pockets of Australia, usually in areas where a large number of people live that come from countries where hepatitis B is endemic, where the prevalence is much higher. So it's very uneven distribution of hepatitis B prevalence across the country. And in Australia, the estimates are that about 60% of people living with hepatitis B are diagnosed, only about 8% tested for hepatitis B DNA, and only about 5% receiving antiviral therapy. We developed a national strategy in hepatitis B in 2014, and there is in that strategy, similar to the documents from WHO, an emphasis on partnerships, on getting culturally competent community engagement, workforce development, and a shift in focus of care for hepatitis B from teaching hospitals to primary care, an initiative that we use very effectively in response to the HIV epidemic. This is the first time that Australia has developed actual targets for our national hepatitis B strategy. The childhood vaccination coverage already is at 95%. There's an increased emphasis on vaccination of priority populations, which is largely people that have immigrated to Australia. A desire to increase the proportion, a target, to increase the proportion diagnosed from 57% to 80% by 2017, and to get antiviral treatment for 5% to 15%. So these are modest targets for a country where I think this should be achievable. And now that we have these WHO strategies, I'm hoping that we will see more reports of what other countries have achieved and what they're aiming to achieve with their national strategies. So finally, I was really quite taken by some recent modelling work that tried to estimate where we should be investing our implementation programs to see the elimination of hepatitis B. And in this modelling paper that was in Lancet Infectious Diseases last year, they defined elimination of hepatitis B as less than 10 per million for incidence and less than 50 per million for HBV-related deaths. And they modelled what the effects would be on if nothing was done, or if there was no prior interventions or just the status quo, if infant vaccination reached certain levels of 90%, for example, if infant vaccination and birth dose vaccination reached certain levels, infant vaccination, birth dose vaccination and peripartum antiviral therapy for viremic mothers, in all the vaccination strategies as well as treatment uptake, and all the vaccination strategies as well as treatment and having a cure by 2025. And they asked with each of these interventions what would have the biggest effect on these targets for elimination. So this summarises what would happen to new cases of chronic HBV in the top panel, people living with HBV in the middle panel, and HBV-related deaths if we just continued to what we did, or if there was status quo in light blue, if there was no historical intervention. I think these graphs just very clearly show that there have been some successes, 310 million Hep B infections averted, 1.1 million deaths, but still a significant number of infections that will occur between 2015 and 2030 if we just continue to do what we're currently doing. They then modelled what would happen if with each of these interventions, infant vaccination, birth dose vaccination, peripartum treatment, treatment of individuals living with Hep B, and treatment and cure. And it's a little hard to see all these different coloured lines on these graphs, so I've just summarised what these interventions would do. If we could scale up infant vaccination rates up to 90%, you'd prevent 4.3 million infections between this 15-year time period, 2015 to 2030. If we scaled up just the birth dose, this would avert 18.7 million infections, peripartum treatment about 500,000 infections. If we could test and treat, and the targets here were around up to 80 to 90%, about 7.3 million deaths. And very interesting that if we did have an effective cure from 2025, most of the impact is on the cost of the delivery of the program, because we do have these effective treatment and prevention strategies. What will all this cost? Well, this is estimates by the WHO, and this actually combines costs to eliminate hepatitis B and C by 2030. And there's a range of different factors that come into these costing estimates. Hepatitis B here is treatment is shown here in blue. Hepatitis C treatment shown here in green. Costs of increasing hepatitis testing services, and then smaller costs of preventing mother-to-child transmission, infant vaccine and harm reduction. And what was striking to me was that total costs estimated to eliminate hepatitis B and C by 2030 was about $5 billion. And this is in contrast to what estimates for reaching 90 for HIV at around $30 billion. So this is really a far lower cost intervention that will be required to see elimination of both hepatitis B and C. So in summary, we have the tools to eliminate hepatitis B with a vaccine and effective treatment, but the major challenge is still in implementation. There's been substantial progress in the uptake of universal vaccination, with a really significant impact on the number of people living with chronic HBV infection, particularly in this region. Tracking the cascade of care globally will be really critical to better define implementation programs and target interventions that are locally and culturally appropriate. And much work really is to be done in implementation. There is a really strong scientific interest in finding a cure, and at least the modelling study suggests that this will reduce long-term costs. So I wanted to thank a lot of my colleagues at the Doherty Institute, where we have a really big program on viral hepatitis. This is largely out of the Victorian Infectious Diseases Reference Laboratory, headed by Mike Catton. Ben Cowie had provided me with a lot of the slides and some really helpful discussion. He heads the World Health Organisation Collaborating Centre for Viral Hepatitis, now based at the Doherty. And Peter Revel, who's leading a regional initiative around hepatitis B cure. I didn't talk about that today. Thanks very much.
Thank you, Sharon, for your great talk. So the next speaker, Juergen Rockstroh. He is a professor of medicine and head of the HIV Outpatient Clinic at the University of Bonn in Germany. And he has extensive research and publication on the HIV, hepatitis B and hepatitis C. And if you go to any conference, you will see him. So I'll often see him.
So you don't have to listen, you can see me at one of the other conferences. No, so after Sharon has moved to HBV cure after the HIV cure debate, I have moved to hepatitis C because that was the low-hanging fruit and obviously the easiest to tackle. So ending viral hepatitis C is obviously easy. And Margaret Hellard, who's a pivotal hepatitis treater from Melbourne, in her opening words to her lecture at the IS pre-workshop on viral hepatitis really phrased it nicely. HCV treatment works, people want treatment and can stop deaths, it can stop transmission, treatment can be cheaper. And that really, I think, says it all. And I could be finished at this point, but you want some... and Sharon said, yeah! But you want a little bit of background around that, so I'll touch upon all these items you see here. So starting with epidemiology and clinical outcome, I think first of all, you have to understand that if you have hepatitis C, in contrast to HIV, it does not always take a chronic course, so you have to separate those who are only antibody positive, may have spontaneous resolved infection, and those who have ongoing replicative hepatitis C. And there has been an overestimation by some of the antibody studies. Sort of, if you open a textbook, you will find many different chapters which open like we have 180 million people living with chronic hepatitis C, which probably is not true. And more recent estimates from various institutes estimate the amount of total viremic infected subjects to be 80 million. And that has a huge impact because that means that cost-wise we have complete different numbers we put into our equations, and that's why I think that is very important. Now, since we were also asked to implement some questions into our talk, I thought I'll use this fantastic, high advanced technical system here and ask you a question, which is, how many people are aware of their hepatitis C infection worldwide? Do you think 75%, 50%, 25%, or less than 10%? So please vote. I'm sure you're doing that already. I think for next year there should be an attempt to include music so you can do a little bit of lambada dancing on stage while voting. We all want to see Sharon dance on the high heels. All right. So the majority says it's less than 10%, and that is absolutely correct. So I think that is one of the shameful messages you have to take home, is that we just simply do not know who has hepatitis C, and that's obviously something we really need to work on. Now, if you look at the distribution of hepatitis C in adults from the available data, I think it becomes clear that this is a disease which is found in a low prevalence globally, and I think just highlights that this is not a country-specific disease. It exists everywhere in the world, which means we need treatment for everyone in the world, and you can see that the highest prevalences are actually found in some Asian regions and African regions, highlighting the need for treatment implementation in these areas of the world. And yes, only 5% are aware of their infection. Clearly, there's a very strong link between IV drug use and prevalence of hepatitis C, with an estimation of probably 2/3 of people who inject drugs having been infected with hepatitis C, really underlining that we need strategies for this particular patient group, and it is mostly a function of policy laws and criminalization which prevents that and therefore paves the way to unhindered further transmission of hepatitis C. Be well aware that there is a considerable overlap of co-infection, and this is true for men who have sex with men, but see there are many white spots, so there's a lack of data in many places, but you can see that all continents now have areas of concern where hepatitis C is also spreading in the HIV positive MSM patient population, but then obviously the highest burden of disease is again found in patients who have a history of injecting drugs, and you can see that on average in most countries this is above 75%, so really the target patient population. Understanding the natural history of disease is important, so when someone gets infected with hepatitis C, around 55 to 85% go on to develop chronic hepatitis C. That is recognizable by a persistently positive hepatitis C RNA 6 months after infection. You can get a little inflammation in the liver and usually have slightly elevated liver transaminases. Then in the further course, after 25 to 30 years, in patients who are mono-infected, a considerable amount of patients will develop liver cirrhosis. Note that this is higher in patients who got infection through blood products, where on average, after that time frame, 30% develop cirrhosis, has been reported much lower in females who got infected. But note that the occurrence of cirrhosis is also not exponential, but increases considerably more when patients turn older. So the toll of disease over extended decades of life expectancy then increases, and you see more liver cirrhosis emerging. Once you have cirrhosis, there is a constant rate of risk for liver failure and hepatocellular carcinoma. That is obviously why we want to treat hepatitis C to prevent these liver disease-related complications. Sharon has walked you very nicely through this Lancet publication, just highlighting that viral hepatitis has really moved up the list of leading causes of mortality among the various diseases you have seen here, with viral hepatitis really being responsible for a considerable amount of deaths per year, again underlining why we want hepatitis C treatment implemented. The courageous WHO strategy of elimination of viral hepatitis as a major public health threat, I think, has really got a lot of countries thinking and has really started many programs. So I think we can be very grateful that this strategy has been developed and is on its way to implementation. You have heard the proposed targets of reducing new infections by 2020 by 30%, and then by 2030 by 90%, and reducing deaths by 10% and then 65% respectively in 2030. That would require that 90% of chronic infections become diagnosed. Remember, we were talking of only 5%, so there's a big way to go. 80% of eligible persons need to be treated, and clearly this will also only come in hand with a linkage to harm reduction programs which need to be implemented as well. Obviously, the success story of antiviral treatment for hepatitis C is a great one, and you can see that after the discovery of hepatitis C, which is really not that long ago in 1989, when first attempts of interferon really led to dismal response rates, how that improved with the addition of ribavirin, the introduction of pegylated interferon, with around 40% of patients achieving cure, but really the breakthrough when the first direct-acting antiviral was added in 2011, so not so long ago, with Vaseprevir and Telaprevir, where suddenly 2/3 of genotype 1 patients achieved cure for hepatitis C, and then eventually with the introduction of various interferon-free DA combinations, achieving cure in over 95% of patients. So clearly, if there is a chance of cure of an infectious disease, hepatitis C becomes such a likely candidate because of these fantastic cure rates. Obviously, we have a whole armamentarium of drugs, and you can see that various steps within the replication cycle and the virus can be targeted. It can be the protease through protease inhibitors targeting the NS3 region, or inhibition of the NS5A replication complex inhibitors, or the polymerase, and you can see that the ending sort of gives away which drug class targets which part of the replication cycle, and it helps you in this quite of difficult terminology to know which kind of combination the respective patient is on. I have to say, though, that in the end it really doesn't matter so much which combination you're using, as long as it's the active ingredient, because all of that seems to mount up to a very high cure rate. And I think it's important to always underline and remember that actually success of therapy is crucially dependent on your fibrosis stage. So if we would all treat everyone early, we wouldn't even have to worry about failures. And I think that's one of the things which is completely missed in discussion, that some of the complications we see are just a result of too late treatment and therefore preventable if everyone would be treated early. There has been, just like the elegant finishing of Sharon's talk with the modeling work, there's been similar modeling work also with regard to hepatitis C-related disease, telling you in the upper left-hand figure that if no treatment is available, that obviously there will be a progression to more advanced liver fibrosis stages, so the different colors or shades represent different liver fibrosis stages as well. In dark, complications of liver disease like decompensation, occurrence of cancer and liver transplantation, which obviously will go unhindered in the setting of not availability of therapy, and only really the increase of diagnosis and the increase of corresponding treatments will lead to the figure in the right-hand bottom, which shows you a dramatic change in the sequelae of liver disease, underlining that this is all possible if these drugs just are managed to be rolled out. So the barriers to treatment are obviously cost, and I'm sure Giten will explore that much more, but I think it's important to note that cost is negotiable, that cost is different from country to country, but if low costs are achievable in certain countries, why are they not achievable in others, and what is the way to make that happen equally in various places? Importantly, first work looking at patients who mostly receive treatment through Bayer's Club, looking at generics, show that the cure rates are absolutely superimposable, also above 95%, really highlighting that it's not a miracle of certain drugs, but really it's the combination which makes it happen. Just highlighting again that if we only treat those with F3, F4 stage fibrosis, we first of all will have more failures, but we're really missing the big part of the cake. And if we want to eliminate hepatitis C, this will only work if hepatitis C per se is a treatment indication beyond aspects of fibrosis stage. You can see that in Europe, looking at the bubble size corresponding to prevalence rate and the treatment uptake, that also some countries have a relatively good access and treatment rate. It's still far behind the WHO targets, which is a representation of not enough people knowing the diagnosis. So even in countries in Germany where everyone can be treated for free, if he's covered by health insurance, you can't work without health insurance coverage, so that is a very likely event. But we just simply don't have great screening programs, so a lot of people remain undiagnosed. There have been big efforts of all stakeholders to write manifestos and unify. And I think one of the things we've learned is that actually unifying of people, bringing stakeholders together has made a difference and had political impact and has made countries start treatment of hepatitis C where you would have not really believed this to happen. Nevertheless, on an international scale, the cascade of care for hepatitis C is dismal in comparison to HIV. You see here the amount of diagnosed patients treated and cured, and you can see the numbers are still pitiful in regard to what we have in our hands for treating. This all will only work if there is high-quality harm reduction. There is no sense of having an elimination program without also establishing needle exchange programs and opioid substitution. You know that in many countries of the world this is only very scarcely available, clearly hindering success of HCV implementation. Although all studies, and this is just one from the UK, there are many others which really show that the combination of opioid substitution and high coverage needle exchange program dramatically reduce new infections. So we have the tools, we just have to use them. Now, putting hepatitis C in elimination, I just want to show two examples which I found interesting, because when we had the very first discussions and workshops before the IS conference, there's always a hepatitis co-infection workshop, we were talking about the lack of implementation, the high prices. But last year, suddenly everything already changed because there were all these examples of countries which made a move. Crucially, because someone in the health ministry was ready and willing to make a step forward and say, yes, we can do that. And I think Egypt is a great example because they probably have the highest prevalence of hepatitis C following their bilharziosis eradication program, which led to a lot of nosocomial infections. And you can see that they have an ambitious nationwide program of treating 350,000 patients. Over 220 already have started treatment, and you can see that the success rates are very comparable to what we've seen in any other country of the world. But telling you that if people unify and if countries have an aggressive policy, company interaction, prices go down, and large-scale treatment becomes feasible. You know that the drug is provided for free in Georgia from Gilead in an elimination model research program, and also here very high success rates are achievable, and they're combining that with all kind of harm reduction programs and screening programs, and hopefully will show us a decline in new infections and toll of liver disease burden very shortly. But what I want to end with is issues around hepatitis C reinfection, because I think being able to treat something successfully is one thing, but you do not achieve protection against reinfection, so that's something we need to deal with. So my second question for you is really, how high is the hepatitis C relapse rate in successfully treated HIV, HCV co-infected MSM after 2 years of follow-up? Is it 50%, is it 25%, or is it less than 10%? So how likely are people to reinfect after spontaneously clearing or having successful treatment? All right. So the majority would say less than 10%. And the truth is it's in the middle. It's around 25%. And there's a very nice meta-analysis by Andrew Hill's group which looked at the risk of recurrence, so after being successfully treated, who gets reinfected. So obviously, if you have a low risk for reinfection because you got infected through a blood transfusion and you're not going to get a blood transfusion again, and blood transfusions are also screened these days, well, then there's hardly any risk. If you're an IV drug user and there's lack of harm reduction or you are incarcerated, then you're at a suitable risk of reinfection of around 13%. But if you're an MSM, and we all know that sexual behavior is the most difficult to change, then it's 21% in that study. In Europe, we have a study called PROBE-C. It's an acute hepatitis C study where we gather information of all acute hepatitis C and HIV-positive MSM. We have 600 individuals in that study. And if we look at the reinfection rate, you can see that that mounts up to 24.6%. So really highlighting that we also need other interventions, particularly for MSM, because first of all, drug use is different. They don't identify as IV drug users, so harm reduction is difficult to implement and needs other strategies and messages. There's been nice modeling work from the Swiss group looking at treatment as prevention and risk behavior, and I think the main message from this paper is that even if you would increase treatment uptake, this will not necessarily eliminate the disease. So I think on top of DAA administration and uptake of therapy, we also need behavioral interventions and deal with these issues in this ongoing epidemic around the world. And the final aspect I want to raise is that that sort of underlines the pathway to, is there a potential impact of a hepatitis C vaccine for people, for the MSM population, or for people who inject drugs. I think that is still something, if we would have it available, which would be very useful. So I think there should also be efforts to further work on the hepatitis C vaccine, although that seems to be quite difficult. So in summary, elimination of hepatitis C is feasible, but it really requires a multi-stakeholder effort, which clearly includes increased testing, high-quality harm reduction, improved quality of health services, increased access to treatment. I think a vaccine could play a pivotal role, and reduction in stigma and discrimination, which comes with this disease. And I'd like to close by thanking these wonderful colleagues who've helped me with slides and comments, and thank you for your attention this late in the afternoon. Thank you very much.
Thank you, Juergen, for your wonderful talk. So we come to the important. We cannot ending hepatitis B and C without affordable drug. This important area will be developed by Giten Khwairakpam. So he is a project manager for community and policy Treat Asia, and he has worked a lot on raising hepatitis C awareness and negotiate with the so many pharmaceutical company for the affordable drug, and he saved so many my patients' lives. So if you want to get affordable drug, just go to see Giten. So Giten, please tell us.
Yeah. Thank you so much, Dr. Anchalee. Good afternoon, ladies and gentlemen, and thank you for staying back till the last session of the symposium. I'm going to make this interesting for you guys, so please bear with me for 15 minutes. All of us in this room either practice or live in an environment where we cannot compromise, or the word that is most talked about in public health is access to medicines. We are living in a very, very challenging environment where access with affordable pricing and availability is becoming more and more limited. In this case, we're going to talk today about access to hepatitis B and hepatitis C medications. Just to give you an outline of what I'm going to talk through for you, I'll take you through the direct-acting antivirals, which are known, which Dr. Juergen talked about, and its availability in the region. I would specifically focus more on the WHO CRO region and the WIPRO region. I will also talk about hepatitis B medications that is available in the region. Then we'll move on to the pricing of hepatitis B and hepatitis C medicines. More importantly, how is it that it's being accessed by people, by physicians, by patients across? And then we will look at how is it, what is it that needs to happen to improve access. And Dr. Juergen's presentation has actually laid a very good ground for me, and also some of Sharon's points onto what I'm going to follow through. Let's look at where are all these medicines. We know that Sovaldi has been there. Many of you in this room must have seen it or used it to treat your patients. We have seen Harvoni, the co-formulation of sofosbuvir and ledipasvir. We also have seen Daclenza, which is a daclatasvir from Bristol-Myers Squibb. We also have seen that generic versions of this products have come across either from licensed companies, which are given a voluntary license by Gilead or BMS, and also by other unlicensed companies that have come out. But we know that there are generic versions of generic sofosbuvir, there is generic version of ledipasvir and sofosbuvir, and there is also generic version of daclatasvir. Where are these medicines? We have to know where are these medicines. So in terms of, in the Southeast Asian region, we have, in Thailand, we have Sovaldi and Daclenza, and have just been told that we also have Harvoni registered here, which is the co-formulation of sofosbuvir and ledipasvir. In Indonesia, we have sofosbuvir, and some days ago, Indonesia have included sofosbuvir in its national essential medicine list, or what they call as a national formulary. So that's a good step there. In Bangladesh, we have all the formulations which are coming out in generic form, including belvitasvir. In Myanmar, the generic versions of Soflat and daclatasvir has been approved. In Nepal, we have all the generic forms of the AAs available, including velpatasvir, which has been launched by an Indian company very recently. In India, we have sofosbuvir, ledipasvir, sof, and daclatasvir that has been marketed by several companies which are under license from the originator. And we have velpatasvir in the process of approval by the Drug Controller General in India. In the case of the Western Pacific Regional Office, we have Cambodia with sof and ledipasvir and sofosbuvir. In Philippines, we have Sovaldi approved. In Vietnam, it's sofosbuvir. In Malaysia, we have the EVI combination and also Sovaldi that is registered. You would see that in Vietnam, there is something which is called a special import, and I will come to that later at some point, that this is a process which is allowed by the National Drug Regulator to import unregistered medicines in a country. And this is being practiced in Indonesia, this is done in Myanmar, this is done in also Vietnam. Now, what about the hepatitis B in the region? We know that tenofovir is there, which is Variad. We also know Baraclude is there. Many of us have used this, either as patients or as physicians. We have used generic tenofovir from many countries, from many generic companies. We also have seen generic entecavir from many Indian companies that has come forward. What is the registration status? Where are these medications? In terms of Variad, in our region, it is registered for hepatitis B in 9 countries. Overall, I think it's 81 countries that has been approved for hepatitis B use. And in our region, excluding Mongolia, which is close, but in Wipro, but excluding that, it's only 9 countries that has approved tenofovir for hepatitis B use. Baraclude, which is the originator trade name for entecavir, we have no idea of what is the registration status. We also don't know the generic tenofovir registration status for use of hepatitis B. We know that's there for HIV-related use, but we don't know what is the status of this for hepatitis B-related use. It's the same situation for generic entecavir too. So this is a situation that we are in terms of hepatitis B losing a bit of a limelight compared to hepatitis C. Back to the hepatitis C. What is the cost? We talked about, we were talking about $1,000 a pill a long time ago as a list price in the United States. Right now, we can get a bottle of sofosbuvir, the generic version, for $60 a bottle. A daclatasvir, $30 a bottle. And sof and ledipasvir co-formulation, approximately $97 a bottle. So if you put that together, a soft-DAC combination for 12 weeks would cost you approximately $270, and sofosbuvir and ledipasvir would cost around $291. That works out to around 9,000 to 10,000 baht for the people who are from this country here. And that's something which the government here definitely can think about. In terms of hepatitis B medication, how much does it cost? And these are from different various pricing points in Thailand and also from the generic manufacturers in India. Variat would cost approximately $39 here in Thailand. The generic tenofovir would cost around 16 USD per month. Baraclude, if you want to use the originator and entecavir, it can cost, depending on where you purchase this, from 214 to 386 US dollars per month. And for generic entecavir, it would cost you the most 15 US dollars for a month. So you can see the various options that patients can choose from depending on their affordability and depending on what they can access to. Then we know these medicines are there, we know the pricing. Then how are this being, the DAAs and hepatitis B medications are being accessed? The first process is a national regulatory drug approval. So like how the Thai FDA or BPOM in Indonesia would approve it for use in the country and giving marketing approval. That's the first step. And we have seen where all that has happened in our setting. At the hospital level, there are special import license, and that happens. Cipto Hospital or an NHTD, Cipto in Indonesia, Jakarta, NHTD in Hanoi does this regularly. They take special import license from their FDA to get these unregistered medicines to be used for their patients. So this is something which is allowed by the import rules of the country. At the patient level, we have named patient import, which is allowed again in many countries where a patient needs life-saving medicines. And industry representatives sometimes calls this as compassionate use too. So this is one way of doing it. We have different buyers clubs that are functioning by people living with or HIV or people who use drugs organizations who are facilitating people to access these medications. One can also access this from very large pharmacies in India. So these are potential options of purchasing these medications. Whereas in the case of hepatitis B, unless one has, in most of the cases, unless one has HIV, you will not get tenofovir. So what do patients do? Do you get HIV and come back to get that tenofovir? Or in many cases, patients are not tested for hepatitis B and continuing them on AZT-based regimen, whereas a simple hepatitis B test could have been managed with a single could have managed both the infection with that single medication. So that's a gap that we have at the moment. Looking ahead, what are we going to do now? Now we talked about the 5%. Only 5% knows about this. How do we find that 95% gap? And then ensure that all those patients that we find are followed through that final end of the cascade of care. As I'm sure many of you must be aware, WHO recently approved the first antibody, pre-qualified the first antibody kit from a South Korean company. That's a very positive way forward. But we have to find those patients and then follow through with other diagnostics, including RNA test and fibrosis to assess the liver damage. So that is something that we have to look forward if we have to eliminate. We need faster drug registrations. The FDAs are taking a lot of time. And of course, there are processes and policies that are in place that is required to ensure that the medications that are being brought into the country are safe for use by the citizens of that country. But are there any ways to waive that? There are countries which have definitely waived their requirements to get these medications. And is there a way to get newer drugs, to get more options to physicians and to patients to get these drugs faster? Affordability and pricing. This is again a critical factor, as Dr. Juergen had just pointed out. From October 2015 to September 2016, Egypt treated 670,000 people of hepatitis C. How? Because they have the cheapest medication globally. They could do that. They can manage to treat those people. The pricing that is offered by all the originator companies is appealing enough to treat 670,000 people on this medication. In India, we have the lower pricing, as I had just pointed out. And that price, approximately that price supplied in hospital includes 2 viral load tests and a genotyping test. It might be surprising because that's not even half, the drug cost is not even half the price of the diagnostics that is conducted in Thailand. But that's being done there. How is it possible that's being done? So when affordability and pricing becomes appealing to the government, and when the government feels that they can absorb it, Egypt is an example where mass scale of people are being provided with treatment under the National Health Program. We also talked, Sharon just pointed out that the Hepatitis B vaccination improved from 5% to 15%. And that can happen. That can happen when we specialize, when we improve the skills for Hepatitis C treatment among non-specialists. And all these drugs are coming out from India. They have approximately 2,500 gastro doctors in that country, and out of which 650 have ever treated hepatitis C. All the drugs are there. The physicians are not available. How are you going to, and they have 8 million viremic cases. How is 650 physicians going to treat 8 million viremic cases? By 2030, if you work out the manpower number of these, is that something feasible? Is this an option that we look to say that non-specialists in our primary care, can they be skilled? And you, or many of you must have seen the poster that came out in Croy last year from University of Maryland of comparing specialists along with RMPs and registered nurses. So everybody has fared well. These drugs have not been proven to be very complicated. The last and very challenging thing for many of us is addressing the issues beyond patent. These drugs are not patented in Thailand. Here in Thailand, it's not patented. But do Thai physicians have an option to get the generic version, as I pointed out, those prices? No. Do Thai patients get those prices? Thai patients get at that prices? How many Thai patients can pay 400,000 baht in 3 months? That's the cost that we have to pay in 3 months if we have to cure ourselves. You will remember about, I don't know how many of you are tracking, but we just completed 10 years of the first compulsory license on efavirenz. And the secretary, the former secretary of Thai FDA has said that we need to control the price of drugs. In a seminar which AIDS Access Foundation and other civil society organizations organized here 4 days ago, the Department of Internal Trade has to control the price and make these pharmaceutical companies declare their price based on their production cost. And the FDA should give experts to assess whether those pricing that the companies have declared are actually true or not. People are recognizing that we don't have patent on these drugs in this country. We cannot get it still, and we have to pay 400,000, 300,000 baht only for the medicine cost, excluding the diagnostics. Is that something that the Thai people can actually afford? If we are given at 9,000 baht, don't you all think that the National Health Security Office will think and think about including this medication in the National Essential Medicine list, which will allow most of our citizens to get access to this medicine? So it's a mixed combination of finding the patient, the drugs to be available, the physician's capacity to be built, along with addressing the very, very challenging idea of how do we address all this exclusion under the voluntary license. And except in one license, Thailand has been excluded in all the voluntary license across all treatment, across all medications. Let's think about it as we disembark from this symposium after 3 days, and I'll be happy to answer any questions either after this or post the symposium. Thank you very much.
So thank you, Giten, for your wonderful talk. So just summarize for the these slides, and then we will open for discussion and question. The last slide, yes. Just these slides. Oh.ขอสไลด์สุดท้ายหน่อยฮะ
It's there.
Oh, I'm sorry. So you know, this year is 2017. So you can see that the target 2020, how far is that? It's less than 3 years. Have we done anything better compared to last year? So especially the testing for hepatitis B and C, we hope to meet the target at 30%. So now it's just only 5%. Those for positive hepatitis B and C, they should be treated, about 50% of them. And those who are treated should have, about 90% should have hepatitis B suppression or hepatitis C cure. It's less than 3 years now, so we have started doing something, right? As Giten said, everyone talk about. Starting from today, after you go back, we maybe think about the implementation for hepatitis B vaccine, as Sharon has mentioned. And how about raising awareness and testing for many patients who at least linkage them to care and enroll them in care, and staging whether they have liver disease and they require the treatment or not, and engage them to the treatment, retention, advanced monitoring system, and finally, retreatment for failure or reinfection. So we have to use HIV model. So for hepatitis B and C, it's like we are in kindergarten level compared to HIV, maybe in master degree or PhD degree, right? So we have to push it up. So it's time for discussion, question now. Please come to microphone, please.
Everyone's tired, I think. There's a question in the back. Question in the back? There's a question in the back.
Hello.
Oh, yes, Annette.
So I'm Annette Sohn. I'm Giten's boss. Hello. I'm the director of the Treat Asia program. Sharon, your slide that reminded us it only cost $5 billion to control hepatitis. Is that correct? I mean, like, I'm sort of surprised, because if it really costs $5 billion to control hepatitis, what I don't understand is why there's not more energy behind achieving that cure. I think the world likes a win. Like Thailand loved eliminating mother-to-child transmission. It's hard to get a win in HIV right now. Can we get a win in hepatitis? That would be incredible. I don't really understand what the politics are behind the lack of funding for that.
Yeah, I was also quite struck by those numbers which come from WHO costings. I'm not sure I'm the best person to comment on the politics around advocacy, but I think what really turned HIV around, because I've obviously got a lot more experience in the HIV world, was, organisations like the Global Fund, UNAIDS, PEPFAR, these which hepatitis hasn't had a similar equivalent global major advocacy initiative. And I think that if you look at what really turned around treatment access in low-income countries, it was PEPFAR and the Global Fund, and it needs that sort of level of commitment. And I I think the WHO are trying to make, have done quite a lot with these strategies. The others, I think, will be better qualified to comment. But the wins would be huge here. You know, you have the kind of tools here are really so much even better than what you have for HIV. I don't have an answer other than those initiatives in HIV made a major difference. I don't know what is happening at the advocacy level for similar programs in hepatitis. I'm sure my two panelists will be able to comment on that.
Yeah, so I don't think I'm qualified to say anything better than what you could say. That's not thinkable for me, but I think first of all, I think the cost is obviously dependent on where you get the drugs from. So if you take the German cost for DAs, that's never going to be 5 billion, it's going to be much more. But I think what Giten has showed you is that the prices have come down so substantially low. And obviously the big difference between HIV and the hepatitis, at least C virus, is that it is a probably 12-week or 8-week scenario, and then you're sort of, if you have good harm reduction, and then you will not have to deal with that disease anymore. So it's a very limited, whereas HIV is a continuum of care, and with normal life expectancy is going to be a driving cost issue. Global funding, which has played a huge role for HIV, will not be implementable for hepatitis. I think that is something where people are refraining from, and I don't really see that happen. But what I've learned is in this whole discussion is that it really depends on, in the end, of political players who are willing to sit down with community activists and physicians and move things forward. And the most fascinating thing is that countries where you would never expect it suddenly have huge treatment programs. And what I've learned is it's so much driven by what do individual countries accomplish in the negotiation with countries. So for example, in Germany, the price is set. The company can say, I want so much. And then a negotiation starts and they get very close to the price they ask. So there's obviously, everything is possible. In other countries like Italy, they say, we have so many hepatitis C infections, we're never ever going to be able to pay the German price. So there is no drug access until the negotiation is over. And that can take several years. So it takes maybe 2 years before the Italians get their drug. But what they negotiated is they said, the more patients we treat, the lower the price becomes. So they're now down to 4,000 euros compared to 60,000 in Germany, which is a huge difference, and they're treating much more. So I think in the end it's also like the fantasy of how can you in your system implement that price, but it needs someone to say, I have a will to make that happen. And unfortunately, I think in many countries it's just groups of patients which are criminalized, stigmatized, and they don't have speakers for them. And if that suddenly turns around and they have a voice and people get together, then that happens. And even in countries like Ukraine and other places, you can see actually very active treatment programs in place. So I think what I've learned is, for me, the biggest surprise in hepatitis C is that from very high prices in the beginning, you will now see that all countries are at least treating some patient. I think it's wrong to only treat the cirrhotics, but once people see the success and how easy it is such a strong motivation. So I would see not so pessimistic, just because there has been so much progress over the last years. Think of Portugal, where you would think that's one of the poorer European countries, and they're treating everyone now. So I think there's room, and I think also even in Andrews Hill, very dramatic presentation of low prices of generics, that price has in reality even gone down more because suddenly the use of drugs has increased more than people would have envisioned.
Giten, do you have any comment?
Can I ask another question? Is that okay? Can I
Yes,
ask another
yes.
question? So Giten, great talk. One of the things that you emphasized was the need for non-specialists to deliver care. Actually, you and I talk all the time. I didn't know about the total number of gastroenterologists who treat hepatitis C in India versus the total number of people who are infected. Now, Juergen, you're a gastroenterologist, is that?
No. I'm not smart enough for that. I'm an ID physician.
Oh, that's so funny. All this time I thought you were a GI doc. But as in terms of maybe looking at Germany or looking at Australia, do you think the specialists will allow you, the non-specialists, to treat? Because here in Thailand, I believe it's an issue, Dr. Anchalee, that only GI doctors are allowed to prescribe these medicines in the National Health Program. And if we have to wait in the queue at the public hospital it's not going to happen. So
Yeah.
I'm curious about high-income country, and maybe Dr. Anchalee, if you could talk about the situation in Thailand. Thank you.
Yeah, I might just comment about Australia and again what strong leadership can do. When the drugs were when hepatitis C drugs were funded in Australia, the government negotiated a similar deal to what Juergen's talking about, that above a certain ceiling they became cheaper. Took tremendous advocacy, community engagement, leadership from the academic and government sectors. But they were licensed for both, the government really said, no, primary practitioners should be able to prescribe these drugs. And then a whole series of programs have gone into upskill. And it was based around the HIV prescribing programs we have, where you had to have some limited accreditation. So if the governments determine how drugs are rolled out, at least in a country like Australia where they fund them, and of course we had those wars between specialists and GPs, and I think there's still a lot of interest in even nurse practitioners or other community-based administration, again, like we've seen can be successfully done in HIV. So in Australia, at least, the drugs were licensed with exactly those instructions in place, that this will not just be hospital administered, because we'll never be able to roll it out. You might comment.
So let me just add some points. So I'm an ID physician, but I work in the Department of Gastroenterology Hepatology. So I'm the only sort of pure ID. Everyone else is gastroenterology hepatology, which has been very inspiring for me because I learned a lot from them. So the first thing is, I think if you have advanced cirrhosis, you have to see a specialist. So that's something we shouldn't forget. As easy as these drugs are, if you have advanced cirrhosis, there are typical complications, and that belongs into the hand of a gastroenterologist. Just to keep that in mind. In Germany, traditionally, as well as in the United States, gastroenterologists are not very keen in treating hepatitis C people because they make their money through endoscopic procedures, and there's very little interest, and that's, I think, one of the main reasons why that group has been reluctant for many areas to treat patients, because they really prefer doing other things. And so ID has always stepped in because of the co-infection people. They were automatically in there. In Germany, it's very split. All ID physicians also have mono-infected patients and treat them. There's absolutely no agony between the two disciplines. Primary care providers have been very reluctant because of the high price, and if you get into some kind of problem with the health insurance company, then you are personally liable as a physician, so everyone's afraid of having to pay the 60,000 euro himself. And that has been a major restriction. But I think what we shouldn't forget is that the availability of increasingly pan-genotypic regimen, which will decrease pre-diagnostic requirement, because obviously if we want to treat patients in Africa, we're not going to go through a whole plethora of different kind of molecular tests. That is never ever going to be feasible. But we're going to have a point of core, a core antigen test which says you have ongoing replicative hepatitis C, get a pan-genotypic 12-week, and that's it. One thing, one test, and that's all. And I think when that happens, we really need to involve other disciplines, because otherwise we're never able to tackle hepatitis C correspondingly.
Yeah, I think Thailand is also the same. So once we get the oral drug, so the thing gonna be changed. So the treatment will not be limited just only for hepatologists. Yeah. So Jockey, please.
Thank you, Dr. Anchalee. My name is Giten Khwairakpam from the Access Foundation. It's the NGOs working in Thailand to do the policy advocacy with the Thai government to promote access to medicine, particularly on HIV/AIDS and hepatitis C. So now, I agree with many presentations that we have lots of barriers, starting from the social awareness on the hepatitis C, also the diagnostic and monitoring testing as well, and also the access to treatment is we have lots of the barrier in that processes. And I agree with the director of the Treat Asia as well. She mentioned about limitation of the people access to the treatment because of we have to have the GI doctor to prescribe the medicine for the people. What my organization have done, we tried several ways to advocate with the government to scale up the access to hepatitis C treatment, but it seems like we have lots of problems in terms of price. The price is quite high, and the government is quite reluctant to include the HCV DAA into the National Assistance Drug List. So that means that our Universal Coverage Scheme cannot provide such kind of medicine to the people. And now we try to communicate with the government that to consider to include HCV DAA into the system. But the question is around the price. I require to know more information about, in case of Egypt, they can scale up the treatment, the people can access to the treatment because the price is quite low. I would like to get from how the Egyptians can do that and why the other countries cannot do. And Giten mentioned about voluntary licensing as well. I would like to know what's the criteria that Gilead use it to consider which country can buy the cheaper generic Sofosbuvir from India. Just only 121 countries that are eligible to that the license, and about the other country, particularly the middle-income country like Thailand, and the other 50 middle-income country cannot make use of the license to buy the generic, the DA from India. And I also had a question from friends who are the people living with HIV/AIDS who have the hepatitis C infection as well. When they heard about the news that we have the affordable medicine available in India, but they had the voluntary licensing, can we fly to India to buy it or not? And someone told me that have another regulation they call anti-diversion. Maybe Giten can mention what it is and why it's become another barrier preventing people to access to the treatment. Thank you.
Yeah.
Thank you, Jockey. The first question is around what criteria does licensees or licensors apply to include or exclude a country. Basically, there's no criteria. They have taken some sort, when the negotiations happen between the originator companies and the generic companies who would be receiving the license, or on the other side, either through the medicines patent pool and the originator, they have agreed on certain countries which would be as included territory and which would be as excluded territory. In certain cases, the companies have taken into account the economic status of the countries which are outside of the World Bank classification. So they have their own classification of which is to include and which is to exclude. As I said, in all except for valganciclovir and now the dolutegravir, only in the pediatric, this is the only one where Thailand has been included. The rest, everywhere Thailand has been excluded. What was I didn't write down the question.
Can you fly to India and buy?
Yes. So that is the thing. So basically, we have to do more work to say that when voluntary licenses, the support has to come from physicians, the support has to come from patient groups, the support has to come from civil society, and even from the government to say that why is it that our country has been repeatedly excluded from, do you see us as a very lucrative market like Singapore or Malaysia, or why is it that Thai patients are being excluded from receiving this medicine? The other one is anybody can go and then purchase this medication from India. You have to know where to go and then find it. You might not get it at the price that I have said, because they're businessmen there and they would also want to charge, when a foreigner comes in, they would want to charge more. So anybody can go and then definitely can purchase this. Please just be careful about where you go and where you purchase it, just so as to avoid purchasing from spurious sources or which can potentially be not genuine. So that's the only thing which hasn't been really much of a concern till now, but it's just good to be careful with that.
Yeah, Ajahn Prapai.
You can see why we put this session at the last session of the conference, because we know that we will attract a lot of good speakers and a lot of discussions along this line. For what I feel is just the braveness at various levels. For example, why Thai FDA is not brave enough to license generic hepatitis C treatment, whereas Vietnamese, Indonesia and so on, they license it. So this braveness of government. At the same time, braveness of the academician, for example, why the gastroenterologist or why Professor Juergen would not say all HCV people should be treated right away rather than to wait until fibrosis or whatever. Okay? Professor Juergen will not be able to talk to, or bravely talk to the company that we have to force the price. So just allow the company to gradually reduce the price, maybe 10 years before the price will be available for all German with hepatitis C to be treated. So because, Professor, the academician, they cannot say this kind of word because they are also getting the money from the company to do research. Okay, so if Professor Juergen has another private NGO companies like Juergen has, okay, they can say something to the companies on the behalf of this non-profit organization. But at the same time, they also depend on Professor Juergen to come to him for hepatitis C trials. So this kind of braveness that I'm trying to say is something that we need in our medical world, okay? As Anchalee said, we probably, if the government, if the academicians, scientists cannot say it loudly, probably we have to allow, like community people, NGO, to do something. America send money to Iraq or to whatever country to buy weapons to fight some other people. While German government or the Australian government, give some money to the Giten organization, whoever, to try to do something. For example, to get a BioCup for all German patients, Australian patients to do it. Okay, so. I think this is what Anchalee said, that we need this kind of examples of HIV activism to be applied for TB, for hepatitis B, for hepatitis C, in order to eliminate that. Having the medication itself is also another issue. You need, in this conference we talk about community-led health services to allow non-specialists, to allow non-medical professionals, lay people to do the testing, to do the provision of this treatment. Again, by this itself, among medical doctors, they say that this is unacceptable. Okay, we should do it rather than to allow lay people to do it. So we have to be brave enough to say something that this is what needed. Otherwise, we just do the same status quo. Okay, we will not end any diseases up until next 20, 30 years. So I think that this is a good example that we all have to be a little bit braver, a little bit more being activists.
That's right.
Thank you.
So Chandrapan, so why we need someone like you who have a very strong voice? So then you can so your command can go to the government or stakeholders. They listen to you a lot, so why we think that we need someone like you? So any comment on that?
Yeah, I just really think he's so absolutely right, because every time people have a voice, and it's really always the combination of academic people working in the healthcare system, together with community activists, if they have a strong voice and find that one policymaker who's willing to at least think about it, that is always when change occurs. Only in that combination. And even as an academic, like if you think, for example, guidelines can be hugely influential, because you can sort of use, remember your new guidelines for hepatitis C treatment are getting rid of interferon. That's what you can do. You can say there's no longer a role for interferon. You can say there's no longer a discrimination between F3 or F2. You can say treat everybody. And I think that's what, for example, the EASL guidelines are doing. They even now recommend treating of acute hepatitis C, although it's not even in the label. And I think that helps us tremendously in our own countries to say, listen, this is what the guidelines say, and this is what, and so forth. And so we came also from only treat advanced to treat everybody, and that has been a result of a lot of academic intervention. So I think it's right, and we all have a voice, and we all have to unify, and then things move.
Oh, yes.
Could I just raise one comment about, I was really surprised about access to tenofovir for hepatitis B in Asia, which is really incredible given that it's already here anyway and in generic form for HIV. So where's the... Hep C I understand with this massive, highly variable pricing structure, but for tenofovir for Hep B, why can't that be solved? That seems an easier one to solve to me.
The FDA approval for the same compound to be used for different infection has to be different.
Yeah.
Yes. So you still need the company to put that application. So there's no financial driver. But what about generics? Then?
We don't. The generics haven't really gone. To my understanding, they have pursued with the HIV-related ones, not with the hepatitis B ones. In the case of variant, I think it's 114 for HIV compared to 81 for globally. 114 for HIV-related registration against 81 globally for hepatitis B. Out of which 9 are in and around our area. So that's the thing. That's a challenge, and drug companies would have. They also, I think, have limited people to work with the regulator. The regulatory affairs have limited people, and so there might be challenges. The requirements for each of the infection as to what trials have been conducted are going to be different. So the same trial that was conducted will not be applicable for another different infection. So it might. I don't know the reasons as such, but this is just what I'm assuming.
Okay, because the time is ran out, I would like to. So this is the final section, and the time is come to the end, and the time is to say goodbye to everyone. I would like to thank all speakers for their great job.